Welcome everyone and good afternoon from Philadelphia. Welcome to today's Norms and Behavioral Change talk. My name is Samira Sayed and I'm the Managing Director of the Center for Social Norms and Behavioral Dynamics here at the University of Pennsylvania. We have a very compelling agenda for you here today, which you can see here. And we're going to start today with a brief talk by an early career researcher, Sandra Geiger, who is a PhD candidate at the University of Vienna. And this will be followed by the main talk today by Professor Gretchen Chapman from Carnegie Mellon University. After these talks, we'll have a Q&A segment open to all participants towards the end of today's session. For anyone who might be new to this series, the NoBeC talks, or the Norms and Behavioral Change talks, are organized by the Center for Social Norms and Behavioral Dynamics here at Penn, with the support of the Philosophy, Politics, and Economics program, and in partnership with the Masters of Behavioral and Decision Sciences program. The center itself is a research center which provides specialized consulting, research, and training services to organizations throughout the world seeking to enact positive behavioral change. Right here, you can see our schedule that we have lined up through the rest of 2024. And you can visit our website to register for these future talks or follow the QR code here. And just a sort of thing that we want people to keep in mind is that the reason there isn't a talk in October of this year is that we're deeply in the planning stages for a NoBeC conference to be taking place during October. And we will share more details about the conference in due course. The thematic focus is most likely going to be on polarization and democratic norms. So just a heads up on that as well. Lastly, before we turn to our speakers, just a few ground rules that we have. We ask that you should automatically be muted, but if not, we kindly ask you to mute yourself while the speakers are presenting. If possible, please do keep your camera on so we can have a more interactive dialogue today. And for questions, please feel free to use the chat at any time or raise your hand at the end of today's session when we'll have a Q&A. Last but not least, the recordings of these sessions will be uploaded to our website and also to our page on YouTube as well. So with that, I'll turn to our first presentation, which is by an early career researcher, Sandra Geiger. Sandra is a PhD candidate in social and environmental psychology at the University of Vienna. Her work focuses broadly on pro-environmental behavioral change, including what people think others think about environmental problems, pluralistic ignorance, as well as how interventions influence non-targeted behaviors, spillover effects. Just in this moment, I'll stop sharing so that Sandra, you can go ahead and share your screen. And while you do that, I'll just share with everyone that Sandra's presentation today is on the following: what we think others think about climate change, pluralistic ignorance across 11 countries. And so, Sandra, over to you, and thank you so much for joining us.
Thank you very much for introducing me. I'm very excited to talk to you today about our research on climate change beliefs and pluralistic ignorance. So back in 2010, Leveson and colleagues investigated this phenomenon called pluralistic ignorance with regards to climate change beliefs. And what they basically found was that 90% of Australians back then believed in climate change, but Australians thought that this would only be 56%. And this is an example of this bias called pluralistic ignorance. In our study, we were now curious to investigate whether this climate change-related pluralistic ignorance generalizes to other countries beyond Australia. And in the second part, we were also interested in whether simple disclosure intervention, so basically providing information on the actual public opinion on climate change, can promote factors related to climate action. Here are a little bit of details about the project. We conducted an online survey experiment across these 11 countries with a total sample size of around 3,650 people. And the study in general was pre-registered and peer-reviewed and also funded by the Leibniz Institute in Germany. First of all, we asked our participants what their own views on climate change are, and there we have these 5 different options, and they varied in terms of whether participants thought the climate was changing or not, and to what extent human activity is responsible for it. Afterwards, we then asked about their expectations. So specifically, we asked what percentage of your country's citizens do you believe would think the following ways about climate change? And we presented these 5 options again. And yeah, participants indicated a number from 0%, so basically no one holds this belief, to 100%, everybody holds this belief. Afterwards, we then randomly allocated the participants to either the control condition or the intervention condition. And in the control condition, participants basically simply saw their estimates again, so what they previously estimated. And in the intervention condition, we as well presented these estimates, but also presented that they might be interested to know that recent surveys showed, for example, that 78% of Indians believe that the climate is changing and human activity is partly or mainly responsible. So there we basically provided them the actual social norm, and this actual social norm varied between 71% in Indonesia to 88% in Brazil, based on a real YouGov survey. Here you can see once again the actual climate change beliefs in each of the countries. And now, more interestingly, here you can see the distribution of perceived climate change beliefs. And consistent with pluralistic ignorance effects, we find that across all these countries, people underestimate the true percentage of climate change beliefs. And this underestimation, or these pluralistic ignorance effects, varied from around -21% in Brazil to around -8% in Indonesia. Regarding the intervention, we found that people who were exposed to the actual norms were more willing to express their opinion on climate change, however, with a fairly small effect of Cohen's d 0.05. And we also investigated whether people actually update their expectations about others' willingness to change their lifestyles, and also their expectations about others' government support for climate action. And for both of these, we found very small increases of around 1.5%, but non-significant. So people basically didn't really update their expectations about others. And in turn, they also didn't really, the intervention message also didn't really influence whether people are willing to change their own lifestyle with regards to reducing consequences of climate change, and their own support for government action was also not influenced by the intervention message. So to summarize, what can we learn from the study? So first of all, we found very consistent pluralistic ignorance effects across this diverse set of countries beyond Australia, which was demonstrated in the original study. And this is more speculative, but we also saw that these effects are larger in loose cultures compared to tight cultures, for example, Indonesia, India, and China. And this could potentially be because in tight cultures, the norms are clearer, norm violators are punished more for violating the norms, and thus it might actually be easier to perceive the real norm, and therefore we potentially find lower pluralistic ignorance effects. But this is very speculative. And regarding the intervention, we found that the intervention was largely ineffective, except for these very small effects on people's willingness to express their opinions. And this is also more speculative, but we think that this might also be because of the gap between what we actually emphasize, so the climate change beliefs, and our outcomes, which were more related to climate action and policy support. So potentially to actually influence climate action, we would also need to present people with a message or a social norm message that emphasizes climate action. However, this is often a little bit more difficult because not in every country, for example, climate action are majority social norms. And then to finish, I would briefly like to thank everybody who was involved in the study. You can see all the names here. And yeah, if you're interested to learn more about this work, here's the link to the preprint and my contact details. Thank you so much.
Great. Thank you so much, Sandra, for the really compelling talk. And since we'll be moving on, just 2 notes for everyone is that If you have any questions for Sandra, please feel free to put them in the chat and we can come to them later as well during the Q&A. And Sandra, if you'd like, feel free to put your email address or contact information in the chat as well. So with that, we'll go ahead and keep moving forward. I'm just gonna share my screen once more. So with that, yeah, we'll turn to today's main talk, which is gonna be by Professor Gretchen Chapman. Gretchen is a professor in social and decision sciences at Carnegie Mellon University. And previously, she was a distinguished professor of psychology at Rutgers, where she served as department chair of psychology. Just as I continue to introduce you, Gretchen, you can also go ahead and share your screen with your slides. To share this with everyone, Gretchen's research goal is to illuminate the psychological processes underlying decision-making and to harness these findings in the design of theoretically motivated, policy-relevant interventions to facilitate healthy and pro-social behavior, such as vaccination and blood donation. And with that, I'll hand it over to you, Gretchen, and thank you again so much for joining us.
Thank you, Samira, for inviting me, and thanks everyone for being here. Greetings from Pittsburgh. I'm excited to share with you some work that I'm doing with a star second-year PhD student, Jose Arellano, and my faculty colleague, Silvia Saccardo. We're interested in descriptive norms and source effects in pediatric vaccination intentions. Jose is here in this Zoom session, so potentially he may be typing things in the chat to correct any incorrect things I say in this talk or address questions you may have. I've been interested in vaccination behavior for a very long time, and even prior to the pandemic, the World Health Organization declared vaccine hesitancy as one of the top 10 threats to global health. To start off, I'm going to show you this increasing vaccination model that the World Health Organization adopted based on a large review paper that I and a team of wonderful collaborators published a few years ago. And you can see that there are several different categories of factors that causally influence vaccination intentions and behaviors. One of them in the upper left is what people think and feel, so beliefs, risk perceptions, vaccine confidence, that sort of thing. The box that we're going to focus on for today is this social processes box, and I'm highlighting in red the fact that we listed social norms as a contributor to vaccination behavior. At the time that we wrote this review paper, there was lots of evidence that social norms are causally influential in behavior in general, but not a lot of evidence that social norms were impacting vaccination behavior specifically. But in recent years, especially since everyone started studying COVID vaccination, more of that evidence has come to light. The third category here, practical factors, I'm going to come back to that later in the talk. Now, it's very difficult to manipulate social norms themselves. What we can manipulate is some kind of intervention that we think will impact social norms. So, for example, a message about social norms. So we give participants different messages about social norms. We hope and we check that those influence their perceptions of the social norms, and then those perceived social norms presumably impact intentions and therefore behavior. It's possible that there could be moderators of this effect. For example, a message about social norms is going to come from someone, some messenger, and some messengers may be more effective than others, more compelling or more trustworthy. And finally, if our message about social norms influences intentions and behaviors, we think that that's having its action through perceived social norms, but it's possible that that action is through some other mechanism. You've changed vaccine confidence or some other beliefs. And so hence, it's very good when studies will measure the perceived social norms, as Sandra just did in her wonderful talk, in addition to looking at the final outcome of intentions or behavior. Do social norm message interventions influence vaccination intentions and behavior? I'm going to give you a quick tour through some recent literature that shows some mixed evidence for this. In social psychology, it is classic to distinguish between descriptive social norm messages and injunctive social norm messages. Descriptive social norm messages describe what other people are doing. Like you might say 99% of other people have already vaccinated, or most of your friends plan to get vaccinated. An injunctive social norm message describes what someone else, often an authority figure or trusted or respected other person, wants you to do. So your doctor wants you to get vaccinated, or all doctors recommend vaccination. Those would be injunctive social norm messages. Okay, so here is a descriptive norm message study that was conducted in Israel. Participants got either a no information control or a social norm message that said that the vast majority of people stated that they would get a COVID vaccine if it was available. The study was conducted before they were available. And as you can see from the graph on the left, this had absolutely no effect on intentions to vaccinate. Here's a larger study that did show a small and detectable effect of descriptive norm messages. This study included almost 500,000 people in 23 countries. The dependent variable being shown here is this vaccine acceptance scale. In other words, intention to get the COVID vaccine when it was available. And participants were randomized to 4 conditions: a no message condition, a message that wasn't about vaccination, and then 2 descriptive norm messages that the authors described as broad or narrow. The broad message accurately reported the percentage of previous participants who said that they would vaccinate or didn't know if they would vaccinate. So that's a bigger number, like my 96% example here. And the narrow message accurately conveyed the percentage of previous survey participants who said that they would vaccinate, so excluding the don't know. So that's a smaller number, 84%. And those 2 descriptive social norm messages did in fact shift people upwards on this vaccine acceptance scale. The blow up on the right shows the final category where you can kind of see it. It's a small effect. There's 500,000 people, so it's statistically detectable. This same study also assessed norm perception. So what percentage of other people do you think will vaccinate? And you can see that both the narrow and the broad message relative to control updated that norm perception, the broad more so than the narrow. And then the behavioral intention is just the same data that was on the previous slide, but shown in a different way, that the broad and narrow social norm messages increased vaccination intention. Things didn't work quite so smoothly for the other behaviors that they were looking at. Okay, so that was a couple studies on descriptive norm messages. What about injunctive norm messages? Here's a study that used a YouTube video ad of former President Trump urging Americans to get the COVID vaccine. The video was randomized across counties in the US, and vaccination records at the county level were the dependent variable. The effect size was about 100 additional vaccinations per county, and with this sample size, that was not a statistically detectable effect. Here's another couple examples of injunctive norm messages that I'm summarizing here very briefly. A prescriptive norm message about 90% of medical scientists agree that vaccines are safe, or agree that parents should be required to vaccinate their children. That increased the ratings of participants in their public support for vaccines. And the box on the bottom summarizes an older study in which medical residents either did or didn't get a personalized letter from the chief of infectious diseases asking them to get a flu shot. And that increased the number of residents who actually did get a flu shot. One final example of a sort of injunctive norm message. This is another one of these medical consensus messages. This study was conducted in the Czech Republic. And on the left, what you see is the actual results of a survey of medical experts asking them whether they would recommend the vaccine. And of course, the huge majority of them do recommend the vaccine. That actual result from that survey, that literal graph you're seeing on the left of the slide, was then presented to the lay people participants in the study, and that norm message changed their perception of the norm, how many medical experts they think do recommend the vaccine, and also the layperson's vaccination intentions, their willingness to get the vaccine. So as with the descriptive norm messages, we've got a bit of a mix in the literature in terms of how well these injunctive messages work. Now, if you're going to give a norm message, presumably someone is the messenger who's giving that message. Sometimes studies don't specify who the message is, and the participants might very reasonably assume that it's the researchers themselves who are giving the message, but sometimes the messenger is specified, and getting the messenger right can be important. Here's a study that was conducted fairly early on in the US when COVID vaccines were available in North Dakota, which is a fairly conservative geographical region, and the same message was conveyed by different messengers. It was the religious messenger that had the largest impact on vaccination intentions. Some studies have examined lay versus expert messengers. You might think that expert messengers would be more effective because they're experts. What they say would be more trustworthy, but that is not always the case. In the top box here, here's a study that found that actually lay messengers were more effective than expert messengers at increasing vaccination intentions for flu and COVID. And that was especially true among hesitant participants. So lay messengers might be more relatable or could be more trustworthy depending on the outlook of their recipients. And the box on the bottom refers to a study that found no difference between lay and expert messengers. So expert messengers are not always better. All right, what are we going to look at in our study? We focused on descriptive norm messengers and who the messages and who the messengers were. So one question is, do descriptive norm messages increase vaccination intentions relative to a control message? The study was done in a pediatric vaccination context, so the participants are parents. So if we're going to give a descriptive norm message, who is that norm message going to be about? Whose behavior are we going to be describing in that norm message? We could describe the behavior of experts, like what do pediatricians do? How many pediatricians vaccinate their own children? Or we could describe the behavior of lay people. How many parents vaccinate their children? And finally, we're going to vary the messenger. So is the messenger going to be an expert, a pediatrician, or a lay person, a parent? You might think that the lay parent messenger would be more effective because they're more relatable to our parent participants, but you might think that the pediatrician messenger might be more authoritative and therefore more effective. So in our study, we had just shy of 2,500 parents recruited on Prolific last month. They were randomly assigned to 5 conditions. There was a control condition that didn't have any norm message. And the remaining 4 conditions comprised a 2-by-2 design where we varied whether the norm information was about what other parents do or what pediatricians do, and the messenger delivering the message was either a parent or a pediatrician. So let me show you what these messages look like. So here's our control condition. It's just a short message that says, it is important for children to get vaccinated against highly contagious diseases such as MMR, hepatitis B, and chickenpox. So notice that the control condition is talking about vaccination. It's not a complete no information control. And it's also communicating the desirable feature of vaccination, saying that it's important, but there's no descriptive norm information and there's no identified messenger. All right, here's one of the treatment conditions. So we've got a messenger identified as a parent. This is a message from Sophia M., a mother. And the woman in the picture is actually Sophia, and she's actually a mother, and she actually endorsed this message. And the message starts out with the same text as the control condition. It's important for children to get vaccinated, blah, blah, blah. And then it presents some descriptive norm information. So importantly, most parents like myself protect their children by getting them vaccinated. In fact, according to official data, more than 99% of parents in the US have vaccinated their children. So this is norms about parents. And this message is true. If you're wondering where that 99% figure comes from, less than 1% of children in the US receive no vaccines. So 99% of parents give their children at least some vaccines. Okay, next message, still got a messenger who's a mother, but now the norm information is about pediatricians. So most pediatricians who are health experts protect their own children by getting them vaccinated. In fact, according to official data, more than 99% of pediatricians in the US have vaccinated their own children. So the norms are about pediatricians, and that 99% figure comes from a survey, a published survey study. All right, now we're going to switch up the messenger. So now we've got a message from Dr. Sophia M., pediatrician. That picture is really Sophia, and she's really a pediatrician, and she really endorsed this message. And so the pediatrician messenger is going to give this one of the same two messages that we already saw before. So in this version, the descriptive norm message is about what parents do, and then final condition, pediatrician messenger, and the norm information is about pediatricians. After participants saw the message, they completed our dependent variable intention ratings. So these participants are all parents, but we asked them to imagine that in the future you have a new child and rate on a scale from 0 to 100, how likely would you be to get your new child the MMR vaccine, the hepatitis vaccine, and the chickenpox vaccine. Participants rated all of those separately, but then we combined them into one average score for analysis. And then there was a second question about COVID vaccine. So a new updated COVID vaccine is now being offered for everyone ages 6 months and older. How likely would you be to get your new child vaccinated against the COVID vaccine? I'm going to look at a couple of questions in the chat here as we go along. Were lay messengers known to the recipient? No, they were not. Kudos to Jose for finding us the messenger who provided us with her photos, but the participants did not know her. Obviously, that would be a lot more effective, but harder to engineer. Yes, and we didn't have any incentives for accuracy. Okay, so let's look at some data. Towards the end of the survey, we asked people about their confidence that the message that they saw was truthful. Confidence was pretty high, but not universal. But importantly, it didn't differ across the conditions. It wasn't like messages from pediatricians, people were more confident that they were true than messages from parents. All right, let's first look at perceptions of the norm. So were perceptions of parents or pediatricians' vaccination behavior successfully updated by the messages that we gave? So this graph shows perceptions of parents' vaccination behavior. So we asked our participant, what percentage of parents in the US do you think have vaccinated their children against diseases such as MMR, hepatitis B, and chickenpox? So the very diseases that were mentioned in the message itself. Over on the left, we see the control condition at about, their estimate is about 81%. And in the middle, those are the participants who were in the parent norm condition. They were told that 99% of other parents vaccinate their children. They're up at 87%. So that's good. They've updated. We've shifted their perceptions of norms. I am collapsing in this figure across the different messenger conditions. So just looking at who the norm messages were about. And then on the right, we see the participants who were in the pediatrician norm condition. They were told that 99% of pediatricians vaccinate their own children. They have also updated their perception of parents. higher than the control. That also seems reasonable if you learn that almost all pediatricians vaccinate their children, that you might think that's somewhat informative about what parents in general are doing, but they're not updating as much as the parent norm. So far, so good. Here's a density plot just to show the distribution of estimated percentage of parents vaccinating in the 3 conditions. So the blue and pink distributions for the norm messages are shifted to the right of the gray control. If there's a right answer to this question, probably it's 99%. We just told people 99% of parents vaccinate their children. Then we asked how many parents vaccinate their children. You might think that they would say 99%. And in fact, 18% of those in the parent norm condition did say 99%, and that's higher than 2% in the control condition. So we have updated perceptions of norms. Okay, let's look at perceived norms of pediatricians' behavior. So now we ask participants, what percentage of pediatricians in the US do you think have vaccinated their own children against diseases such as MMR, hepatitis B, and chickenpox? Over on the left, we've got the control condition. Also, as in the other measure, down around 81%. And over on the right, we've got those who got the pediatrician norm message. They have updated to around 85%. So very good, we have updating. And in the middle, we have the participants who got the parent norm information. They have also updated. Also, probably reasonable. If you learn that almost all pediatricians vaccinate, if you learn that almost all parents vaccinate their children, you might think, like, presumably at least that much, maybe more, of pediatricians vaccinate their own children. But what we don't have here is a sort of specific double dissociation. We don't have a pattern where the parent message specifically caused people to update their norms about parents, and the pediatrician message specifically got them to update their norms about pediatricians. So either message got them to update their norms about both parents and pediatricians. And for whatever reason, the parent norm message was slightly more effective at getting people to update both of those. Here's that same density plot, but for this pediatrician perception measure. So same pattern as before. In the pediatrician norm condition, 16% of participants gave that perfect 99% answer, and that's higher than 4% in the control condition. Okay, so we have updated norm perceptions, not as specifically to the 2 populations of parents and pediatricians as we might have liked, but we have updated norm perceptions. Is that going to spill over into behavioral intentions? So what messages are going to be the most effective at increasing vaccination intentions? At the time that I sent you all the title and the abstract for this talk, we had not yet run this large pre-registered study. We were about to run it, and we had some pilot data that suggested that these messages were effective. Then we ran the pre-registered study, and this is what we found. We found no effect on vaccination intentions. So this figure here is showing vaccination intentions for getting the MMR, hepatitis B, or chickenpox for your hypothetical future child. Our pre-registered analysis plan entailed a series of contrasts where we first compared the control condition to the 4 message conditions as a group. There's no difference there. And then the remaining contrasts looked at the 2x2 design of the 4 messages, and no main effects and no interactions there. Now, this is intentions about MMR, hepatitis B, and chickenpox, and you can see that all those numbers are pretty high. So we might be dealing with the ceiling effect. People are just so enthusiastic to get these vaccines for their kids that you can't see any difference across conditions. So that was a main reason why we also included a measure of intention to vaccinate against COVID, because that's a newer vaccine, and so people are not as enthusiastic to get it. So these ratings for COVID are lower, less chance of having to deal with a ceiling effect. But again, we don't see any differences across our conditions. We did some exploratory analyses to look at possible heterogeneity. One of the questions that participants answered near the end of the survey was about their political leanings. So a 7-point scale from strong Democrat to strong Republicans. And here you can see that intentions to vaccinate against MMR, Hep B, and chickenpox are pretty strongly correlated with political persuasion. That's not surprising. Many other studies have found that. And in fact, that association is even stronger when we ask about COVID intentions. Although this association with political persuasion is disturbing and interesting in many lights, it's also kind of convenient for researchers. And the reason is that some research indicates that any intervention to try to shift vaccination intentions is most influential for the people in the movable middle, not the people at the ceiling who can't be moved, not the people at the floor who can't be moved, but the people in the middle are going to be most malleable. And Democrats tend to be at the ceiling. Republicans tend to be lower down, so perhaps more in the movable middle. So we can use political persuasion as a kind of proxy for baseline tendency to vaccinate. And in so doing, perhaps we'll see a larger effect for the more Republican participants because they are more in the movable middle range. So we did some exploratory analyses looking to see whether this politics measure moderated any of our pre-planned contrasts in the analysis. And here's what we found. So this figure shows vaccination intentions against COVID. And what we found is the opposite of what we had guessed and what I just explained. The messages as a group compared to control there's more of a difference between any message and no message for Democrats than for Republicans. Now, this same pattern does not occur when we look at vaccination intentions for MMR, Hep B, and chickenpox. It only shows up for COVID. And for COVID, the Republicans are like really low. So I don't know, maybe we're dealing with a floor effect and we can't shift the Republicans, and it's the Democrats who are more in the movable middle. That's totally post hoc. Maybe because COVID is more polarizing, the Republicans are showing more of a reactance, some of them anyway, and that counteracts any treatment effect. But we only saw this interaction with the COVID intentions, not with the MMR, chickenpox, and Hep B intentions, and it's only for comparing any message to control. None of our 2x2 analyses looking between the different messages was moderated by politics. Okay, so we don't have a lot of evidence in this study that social descriptive norm messages are influencing vaccination intentions. So if we can't use norm messages to influence vaccination messages, what could we use? Well, I'm going to direct us back to this increasing vaccination model. The third box, the blue box, is what the WHO calls practical factors. In our original paper, we described this as intervening on behavior directly. So don't try to change people's beliefs. Don't try to change their risk perception or confidence. Don't try to change their norm perception. Just try to change their behavior. Just go directly to the behavior. So I'm going to show you 2 examples of doing that. This first example is an older study I did on vaccination default appointments. So about 900 outpatients at a medical clinic were randomized to 3 conditions regarding the flu shot. One group got a letter saying, you've been pre-scheduled for a flu shot appointment on Thursday at 7:30. Here's how to change it or cancel it if you don't want it. A second group got an opt-in letter that said, flu shots are available. Here's how to make an appointment if you want one. And then the third group got no letter. And then we tracked actual vaccination records at the clinic. And you can see that the opt-out condition had notably higher vaccination rates, about 10 percentage points higher, which I didn't really appreciate at the time, but I now know that's a pretty big effect for vaccination behavior. Since this is a talk about social norms, you might be thinking, well, maybe default manipulations have their effect by way of social norms. If you get this letter from your doctor pre-scheduling you for an appointment, you might think, my doctor really wants me to get a flu shot. the strong injunctive message. Maybe that's the mechanism. We don't think that's the mechanism in this particular study. And the reason why we think that is that there were two sort of mechanisms for patients to get a flu shot. There were these special early morning flu clinic hours where you had a 5-minute appointment with a nurse just to get a flu shot and nothing else. Vaccination at those hours are shown in the black on this bar graph, and it was those special flu clinic hours that was the topic of the letters. We got a big effect there. But patients could also get vaccinated at a regular doctor's office visit. They had a doctor's office visit scheduled for another reason, a general physical, a med check, something like that. And while they're there, they could also get a flu shot. If what's going on is that the opt-out letter conveyed this strong injunctive norm that my doctor really wants me to get vaccinated, you would think we would also see a difference across conditions in the gray part of the bars, the vaccinating at the doctor's office visits. But we don't. There's no effect there. So that leads us to believe that it's not an injunctive norm mechanism of the default manipulation, at least in this particular study. All right, I'm going to show you one more example of intervening on behavior directly. And this is what is probably the most strong-armed intervention a person or a policymaker could use to encourage vaccination, and that's a requirement or a mandate. In summer of 2021, many long-term care facilities introduced requirements such that their employees had to get the COVID vaccine or they would eventually be terminated from employment. We were able to get an employment data set from a network of long-term care facilities that showed when people were employed and what their vaccination status was at different points in time. This figure that we're looking at right now tracks what happens to different employees through time. So the mandate was announced at the end of July. So that's the dotted line over here on the left-hand side. That's the date that the mandate was announced. We selected all of the employees who were as yet unvaccinated for COVID the day before the mandate was announced. So yellow people in this figure are unvaccinated, but still employed by the long-term care network, and everyone was yellow at the beginning because that's how we selected them. And then we move forward in time to see what happens. There were different compliance deadlines for clinical employees and non-clinical employees. So these other dashed lines show when those dates are. You can see that in the blue section, a number of employees became vaccinated and continued to be active employees. Dark blue is for people who got vaccinated but then left the organization for other reasons. Red is people who did not get vaccinated and separated from the organization for reasons unrelated to this mandate. And then the lighter red shows people who were unvaccinated and then terminated specifically for non-compliance with this mandate. And so, of course, there's big upticks for that at each of the compliance deadlines. And theoretically, by the time we get to the right side of the graph, there shouldn't be any yellow people anymore. Everyone should either be gone or vaccinated. And there's, I guess, a little slop in the system. There are a few people that are still yellow. From an organizational point of view, mandates basically work by definition because everyone's either going to get vaccinated or they're going to leave, and then voila, the organization has 100% vaccination rate or something pretty close. And as long as the organization can replace all the employees who left with new employees who are vaccinated, the organization is happy. We behavioral scientists, we're more interested in whether individual people got vaccinated. So did this mandate actually cause someone to get vaccinated who otherwise wouldn't get vaccinated? Or did it just cause the people who would never have gotten vaccinated to just leave? So to try to address that question, we did an interrupted time series analysis. So this graph shows vaccine coverage at the organizational level across time. Each dot represents the percentage of the workforce who was still active for that week who was vaccinated. So, for a given week, what percent of employees are vaccinated, then move on to the next week, whoever the employees are for that week, what percentage of them are vaccinated. And the vertical dashed line in the middle here, that's the date that the mandate was announced. So we want to see whether the slopes of these lines get steeper to the right than to the left. And they do. So that shows that the rate of increase in coverage of vaccination increases after the mandate was announced relative to before. Now, there are different colors on this graph that refer to employees who were located in different states. This was a multi-state network of long-term care facilities. So some of these facilities were located in states where there was a state-level mandate that people who worked for state-owned long-term care facilities had to get vaccinated. That's the bluish curve here. Some of them worked in states where there was a state-level mandate that all long-term care employees, private or state-owned, had to be vaccinated. That made the mandate from the organization we were studying, its mandate was a little bit less relevant then because the state already had a mandate or was making a mandate. And then the red group, those are participants who worked in states where there was no state-level regulation about mandates at all. So the mandate in the organization that we were studying, their mandate is very influential because it's the only sort of the only player in the picture, the only mandate that's influencing these employees. So that is why the red line shows a bigger increase in slope from before to after. 3.7% of the workforce was eventually terminated for non-vaccination. So absolutely there are costs to mandates. Organizations lose staff. Those staff lose employment. Those are real costs. And this is only an observational study. We don't have any kind of causal manipulation here, but the observational data suggests that mandates are quite effective. Right before the mandate was announced, 82% of employees were vaccinated. And right before they started terminating people for non-compliance with the mandate, that was up to 95%. So that's a 13 percentage point difference. I mean, it's not an experiment, but if we can compare it to other vaccination studies, that is a large effect. So mandates are just about the most heavy-handed and influential intervention that we have for increasing vaccinations, but of course, they have a lot of costs associated with them. They should not be used lightly. All right, I'm going to wrap up here and then look at your questions. So social norm message interventions have a spotty track record in terms of affecting vaccination intentions and behavior. I'm really interested in your thoughts about why social norm messages might be less effective for vaccinations than for other behaviors, and intervening on behavior directly with defaults and mandates and things. Those remain the most effective means for influencing vaccination. All right, I'm now looking at the chat.
Great, thank you so much, Gretchen. And what I can say is that there's been a ton of questions and comments in the chat, a lot of which Jose has already had the chance to respond to, but it would be great to still get any additional thoughts that you have. And just before we turn to questions that are for you, Gretchen, there was one that was directed to Sandra. And I know, Sandra, you responded, but the question was, are there incentives if there's a difference between individual expectations and real values? You responded, Sandra, but was there anything more that you wanted to add to that?
Yeah, so we didn't have incentives for this study, but at least the most recent meta-analysis, although it was across all sorts of domains, not only climate change behaviors, they at least showed that there was no difference in terms of how correct people were when they were incentivized or not. So yeah, not sure whether it matters in this context, but at least in this meta-analysis, they showed there it didn't really matter that much whether people were incentivized or not.
Okay, great. Thank you so much, Sandra. Going down the questions for you, Gretchen, one of them was, This is from Kristen. Curious if you know if anyone has looked at combined norm messaging with political affiliation, a Republican Democrat pediatrician or Republican Democrat mother, since it seems like that social identity is overriding the norm messages.
Well, Rob Willer has done a lot of interesting work on Republican-focused messages. I do not know of any studies that combine the political identity with other identities like pediatrician or parent. Are we thinking there would be an interaction? Or I guess it seems like Kristen thinks that the social identity is going to be more important. So maybe one of the many reasons why we had no difference between our pediatrician and parent messengers is because that distinction just pales in comparison to a political identity distinction. Kristen, feel free to speak up if I'm mischaracterizing your question.
Yeah.
Hi,
Yeah.
this is Kristen. Yeah, that's kind of the idea that I was getting at is like, is there this overriding social identity that's just basically canceling out any type of norm you're trying to establish with the messaging? And I don't know, I was just curious.
Yeah, I think that's quite plausible. Political identity, of course, is a norm of its own, and maybe that's the norm that's driving behavior. And I don't want to do what other parents do. I want to do what other rural Republican parents without a college education do. I need that more proximal norm that's my identity group.
Okay.
And the problem with that is if we accurately portrayed that behavioral norm, it probably wouldn't be 99%. It would be a little bit lower. So it would be numerically less persuasive.
Okay, gotcha. Thanks, Gretchen, and thanks, Kristen, for that question. Another question, there's a couple more. One question is from Harry McKay, and Harry asks, out of curiosity, doing some work with social norms questions myself, how do you handle responses that like 0 or other implausibly low estimates of vaccine uptake?
Well, we had an attention check filter. Towards the end of the survey, we asked people to report the number that they saw. So, I mean, you saw we asked them what % of parents do you think actually vaccinate? They can say anything they want there. But then we said, like, we gave you a message that told you what % of parents vaccinate their kids. What was that number? And of course, the right answer is 99%. They had to say something 90 or above to stay in our analysis. So somebody that gave something really out of line would not be included. Now that's more of an attention. I mean, not more. That is an attention check. Like, did they read our question correctly? I mean, some people really don't want to get vaccinated. So if they give a 0 for their intention, like that could be a legit response. So we keep those in.
Okay, gotcha. Great, thanks, Gretchen. A couple more questions. I see 3 more. One of them is from Liz Barker, and Liz asks, has anyone tried testing norms messaging like parent vaccinations to change perception with a practical ease intervention like default appointment? Does changing perceptions first lift the appointments even more?
So if I'm understanding Liz's idea, we would combine a norm message with a default, and the combination might be stronger than you would predict just from the simple effects of each on its own. A synergistic interaction. I think that's what Liz is getting at.
Right, that's what it sounds like. And also, Liz, feel free to, if you want to unmute yourself and
yes.
Yes, that's right. Yeah, sorry, I commented in the chat. Yeah, an interaction effect. So it wouldn't even necessarily have to be at the same time, perhaps. So maybe sending a perceptions message first and then waiting a few weeks and seeing if people were more receptive to booking an appointment.
Yeah, I do like the response that Jose gave in the chat, because there is evidence, in particular from our other co-author, Silvia Saccardo, that the effect of any manipulation is influenced by the baseline motivation to vaccinate. So if you have an intervention that would only work for someone in the movable middle, and you have someone who's low down in their baseline motivation, if you can use an initial intervention to kind of get them up into the movable middle, then your main intervention might be more influential. So I think that's a wonderful idea. I do not know of any study that has demonstrated that.
Thank you.
Great. Thank you, Gretchen and Liz as well. There's one more question from Liz, and I see two more questions overall. But this next question is, can you be sure the unvaccinated left for other reasons? Maybe they felt pushed out and left out of their own accord for other jobs that did not require vaccines.
Yeah, that is such a great question. We thought about that endlessly. The employment database that we got did list the reason for separation. So in that color-coded flow chart I showed you, the light red people were people who were coded in the employment data set as having been terminated for non-compliance. So that's the employer's records of why they're terminated. It doesn't necessarily reflect like what the person was thinking in their head about why they did. We wanted to do an interrupted time series of analogous to what we looked at for vaccination coverage for separation, because people separate from the organization all the time. There's just kind of like a sort of monthly average of people who leave because people leave jobs. They find other jobs. They take time off to do family responsibilities or whatever. So we wanted to see if that rate of number of employees who leave each week jumped up after the announcement of the mandate. We eventually decided that the data was too sparse for us to get a good estimate of that, but for whatever inadequate analysis we could do, that we didn't find any evidence that there was sort of preemptive quitting before the deadline for termination. But I would not take that statement too seriously, because I don't think the data set was the best for looking at that question.
Gotcha.
Thanks.
Great. Thank you for that, Liz. And the last question we have, which I think is a nice way to wrap up as well, is it's from Natalie. And the question is, do Democrats and Republicans update beliefs differently in response to the norm information? Any difference in overall responsiveness to information, or how they respond differently to expert and layperson norms?
Wow, that is an amazing idea, Natalie. Thank you. We have not looked at that. We only looked at Democrat and Republican differences in vaccination intentions. We did not look at differences in vaccination perceptions, but we're going to go do that right away.
Excellent. Thank you, Natalie, for bringing that up. And really with that, I think this is like a natural place where we can start wrapping up today's session. But thank you so much, Gretchen and Sandra, for your very compelling talks. I think you can see based on the chat, the comments and questions, that it's been really engaging for today's participants. And also thank you very much, Jose, as well, for all of the different responses and comments that you added. I'll just share one last slide before we wrap up for today. But this is just to share with everyone that thank you again for your participation and very active engagement in our talk today, and just consistently as we do these norms and behavioral change talks. Again, today's talk, we'll have it posted on YouTube. And a side note, Gretchen and Sandra will share that link with you once it's posted as well. And we very much look forward to everyone's participation in our next talk, which will be by Dr. Ryan Muldoon from the University at Buffalo. And it'll take place on Thursday, February 15th at 1 p.m. EST. So until then, thank you again, everyone, to our speakers and also participants for your engagement. And we look forward to seeing you next time. Thank you, everyone. Take care.